Good morning and afternoon or evening. Welcome to East Africa webinar on what it takes to sustain government-led scale-up of FP and AYSRH programs. We're going to be getting started in just a few minutes, so please take the time to introduce yourself in the chat and let us know where you're joining us from. Thank you. Once again, welcome to today's webinar. We'll be hearing from our colleagues in East Africa about the experience of graduation looking at geographies in Tanzania, Kenya, and Uganda. I'd like to turn the microphone over to my esteemed colleague, Nancy Alu, who will be today's moderator. Thank you.
Thank you so much, Lisa. Good morning, good afternoon, good evening, everyone. My name is Nancy Alo, working for the TCI project as a county manager, supporting Migori and Nyamira, two of the East African geographies in Kenya. I will be your moderator for the day. So may I take this opportunity to recognize the presence of the TCI global and hub leadership, different geography leadership, key stakeholders, partners and implementers across the globe for honoring this invitation. Feel most welcomed. Today, we've congregated in this virtual space to discuss and share the East Africa experience on graduation. So in East Africa, we have 20 cities that have successfully graduated on their journey towards self-reliance. So leading their family planning and adolescent youth sexual reproductive health programs without direct support from TCI. This was achieved through the institutionalization of the TCI high impact approaches in the graduating geography work plans, so that the geographies could budget for this particular intervention and also liaise with other implementing partners to leverage their support in continuing advocacy efforts post-graduation. So during this webinar, you'll hear directly from the 3 cities that have graduated across the East African hub from the direct support of TCI on their lessons learned around the whole graduation process. You'll also get to hear how cities are still implementing the TCI business as usual model and the high impact intervention post-graduation. And these cities will also be able to share some of the challenges that they have experienced and how they have overcome them and what they have been able to sustain so far. So for those of us that have logged in, kindly, as Lisa had mentioned, register yourself in the chat box to enable us know who is present with us today. And for purposes of registration, type in your name and the organization that you are representing. Just to share some of the housekeeping issues, please keep yourself on mute unless speaking. Please check that you are unmuted if you like to contribute. We'll encourage members of the audience to utilize the chat function to offer comments and questions, and we will respond to comments and questions as they come up. We will also keep a record of the comments and questions for reference at a later stage. However, we'd like you to feel free to ask questions verbally. We know this is a big group, but we would like for our sessions to be very interactive as much as possible. Finally, the recording of these sessions will be shared after the call. Next slide, please. TCI as an organization envisions a world where its population, including the youthful population, women and men, are empowered to live an optimal reproductive life by supporting and partnering with local governments to rapidly and sustainably scale up the family planning and adolescent youth sexual reproductive health proven intervention to help solve the reproductive health problems within the urban poor settlements. Next. So before we get started with the presentation, I'd like to give us some background related to the TCI footprint in East Africa. As TCI, we are providing technical assistance through coaching support to the local governments in Tanzania, Kenya, and Uganda. We are currently working with 46 cities or geographies across the 3 countries in East Africa to implement the family planning proven solutions. Geographies or cities, for those of us who are new to TCI, are equivalent to counties in Kenya, municipalities in Tanzania, and districts in Uganda. Out of the 46 geographies that we are currently implementing in, 15 are adolescent youth sexual reproductive health sites where we provide additional focus and resource specific to adolescent youth sexual reproductive health proven approach. Currently, we are having 20 cities that have graduated across the East African hub with additional new cities coming on board. Some of the new cities include Vihiga in Kenya, Dodoma in Tanzania, and Kibarole and Lira in Uganda. Next slide, please. The TCI journey towards graduation has been a process that is intertwined in the TCI 4-stage model of program implementation, namely the expression of interest, program design, implementation, and ultimately graduation. Normally, cities self-select to partner with the Challenge Initiative to provide quality family planning and AYSRH programming in the various locations within the hub. During the initial phase, cities submit expression of interest to the hub, and once these expression of interest are approved, TCI works with the cities to develop a program design which guides the implementation of the prioritized intervention in the family planning program. To facilitate program implementation, these cities normally commit or set aside some funds for family planning, and in return, they're able to receive additional resources from the Challenge Fund. This startup phase takes an average of 6 months or even shorter, depending on the city context. During the startup period, TCI normally takes the lead in providing technical assistance, which is mainly through coaching. And we see that here the TCI coaches support the cities or geographies in their identification and capacity building of master coaches and the program implementation team members who normally spearhead the implementation process. As cities move towards the surge period, TCI works with them to adapt to the high impact interventions, helps them to cascade the coaching plan down to more master coaches, and help set up to ensure that these cities has a consistently organized, planned, and facilitated coordinated mechanism to support the implementation of activities. And we get that within this phase, the TCI staff also works closely with the management team to engage political leadership and strengthen their capacity on advocacy for policy changes, as we all know, fund allocation, among other program management aspects. This normally place cities in the driver's seat, and we see that cities own these the program at the very beginning and ensure that interventions can be sustained long after TCI leaves the city or after TCI graduates these particular cities. This normally takes a period of around a year after the startup. Then we see that during this phase, coaching also transitions from lead to assist. However, this depends on the context and component that is being supported. There are instances where cities have coaches to support the capacity strengthening, though there might be those interventions that require TCI coaches to take lead. The city implements the high impact intervention, mainly for quality coverage, and as a result, the cities are able to see and document early signals of improved uptake in the modern family planning methods. At the same time, these cities are able to utilize the generated data for action. This normally takes about a year. Thereafter, cities enter the pre-graduation phase, which is based on the results from the RACE tool, demonstrated improvement in its health systems, along strong ownership of the family planning program. For those of us who may be new to the RACE tool, RACE is a reflection and action to improve self-reliance and effectiveness tool. The tool is used by local governments with support from TCI to self-assess progress towards self-reliance. It's normally implemented on a quarterly basis where city key health personnel evaluate the quality and effectiveness of the activities and implementation strength through so that they're able to make necessary course correction. The risk assessment workshop participants normally review relevant external data to validate their scoring, because the assessment has scores of each and every domain. So as participants work to reach out consensus on the scores, they provide evidence in the form of policy, documents, program reports, and even expenditure reports to validate the whole process. The tool normally tracks 4 main domains around political and financial commitment, capacity strengthening, institutionalization and sustained demand of the family planning and adolescent youth sexual reproductive health programs. Then finally, cities are graduated as they achieve self-reliance and sustain the gains that they have made throughout the period of implementation. Graduation is a one-off event that transitions these particular cities to post-graduation phase, where they join the TCI alumni network. Hence, coaching is usually on demand while keeping track of the city's continued progress. Next, Lisa. So I'm going to share briefly the graduation in the TCI context. So as I'd earlier alluded to, graduation is a process where government transitions towards self-reliance, where a city successfully and sustainably implements its family planning best practices, approaches, and achieves both positive results on their health outcomes. Normally, graduation is not an exit strategy, rather a continuum where cities transition to a modified level of support. For instance, when it comes to coaching, it's on demand after ascertaining that there is no internal capacity to do that for purposes of cost efficiency, rather than when TCI takes the lead role as when the cities are new. Additionally, we see that once a city is graduated, there's the building of the local government capacity to be able to work with other donors and in other health areas, so that we ensure that no one is left behind or abandoned for purposes of continuity and sustainability. Lisa, next, please. So in terms of the graduation phases, we say that the graduation process builds the capacity of geographies that partners with the Challenge Initiative to develop sustainable quality family planning and AYSRH programs To move cities along this continuum, TCA engaged.
Nancy, you briefly, we
with the
lost
local
you.
government, like sorry.
We briefly lost you
able
for a
to-
minute. Now we can hear you again. Thank you.
Okay. So in terms of graduation phases, we say that the graduation process builds the capacity of geographies that partners with TCI to develop sustainable family planning and AYSRH programs, and to move cities along the continuum. TCI engagement with the local government follows the defined there.
Okay, Nancy, unfortunately, you've come in and out now. Nigerian Bugwa, are you able to pick up? Let's see. Nancy, are you back?
Are you able to hear me?
Now I can. I don't know why it's coming back and forth. Let's try with the graduation criteria and see if things are okay.
So are you able to hear me?
Now I can.
Okay. So in terms of the graduation criteria, the TCI East African Hub uses both qualitative and quantitative measures to classify graduation. TCI work for a minimum of 3 to reach to a stage of graduation. The hub has developed a graduation stroke resources, stroke teams that will facilitate implementation of family planning and adolescent youth sexual reproductive health intervention post-graduation, and availability of coaches that have been put in place. This is just a sample of the graduation checklist that normally the hub utilizes. Next slide, please. Next slide. So in summary, we are saying that graduation is a process that starts from surge to pre-graduation, moving all the way to post-graduation. And normally it takes an average of 3 years for a geography before initiating the whole process of graduation. Then there is need to use both qualitative and quantitative data to identify potential sites or geographies for graduation, while ensuring that the geography expectations are met or clarified from the onset. Finally, as we graduate, there's normally the need to monitor graduation and the post-graduation processes. Next, please. So at this point, I'm going to introduce our presenters for the day, who are a mix of geography implementers and TCI staff to share the experiences on graduation. So our first presenter is Wamaena Dick. Dick is the infection prevention control focal person and program implementation team member for TCI in Busia district, Uganda, and is passionate about reproductive health and quality service delivery of family planning high impact interventions. Is also a member of the Busia District Health, Family Planning and Quality Improvement Team, as well as a member of the steering committee of a result-based financing project in Busia. Our second presenter is Rehema Panga. Ms. Panga is the Municipal Reproductive and Child Health Coordinator at Ubongo Municipal Council in Tanzania. She oversees implementation of reproductive and child health interventions, including family planning and adolescent health intervention. She's a public health specialist with more than 11 years experience in this particular field. Then finally, we shall be hearing also from Assumpta Matekwa. Ms. Assumpta is the TCI County Manager for Vihiga County in Kenya and 2 other graduated geographies of Kericho and Uasin Gishu. She is a reproductive health expert with over 10 years experience in the implementation of the reproductive health programs in both public and private health facilities. Next, please. So I'm going to invite Dick to take us through the experience from Busia. Welcome, Dick. The floor is yours.
Thank you so much. And I'm representing Busia, as you had introduced me. I will straight away go to the slide that has been displayed. And I'm going to focus on the 5 areas that talks about the key achievements since joining the TCI. You realize that the TCI, of course, has supported us in a number of areas, especially on the high impact interventions that I will be able to mention later. But to be specific and straight to the point, on the dedicated budget lines, you realize that before the support of TCI and on family planning, we did not have any budgetary allocation to the family planning activities as regards to that area. So we had a tremendous support on this area, and remember that after that we graduated. That was 17th March this year, and after the graduation, you realize that the leadership focused on the very fact that we needed to sustain family planning activities in a municipality. So during our planning process, that was in May, we had to, under the directive of the leadership of the mayor, that was after a number of advocacies, there was a budgetary allocation of a 2% allocation out of the total local revenue collected for this within this financial year. That is around 140 million. That is aimed towards supporting family planning activities. And we also realize that this is a very key area that we also included in our 5-year development plan, given under our program called the Human Capital Development. So it is agreed that within the 5-year development plan, we are going to have an incremental rate whereby at the end of the 5 years, we shall have a 5% allocation towards family planning activities. And this is clearly reflected in our approved 5-year development plan. I remember in one of the executive meetings when we were doing the planning of our financial year, the mayor came up during the discussions, and given the fact that his capacity had been built and was focused towards strengthening of the family planning services, he had an allocation of 1 million shillings out of his own fuel to go to family planning activities. This is clearly reflected. So that is how our geography, Busia municipality, we have dedicated a budgetary allocation to family planning activities. And on the second one, on the strengthening of community level activities, we have a structure which the government has put in place. That is the village health teams who are already in place. But we realize that these are volunteers who are doing a number of activities. Of course, before the TCI, their capacity had not been built to do work regards to family planning. But we appreciate the fact that when TCI came, their capacity was built on a number of aspects. You realize that these VHTs were trained on short-term methods. To be more specific, we had Sayana condoms. So they have the skills on how to give out or distribute the family planning commodities. We call it community-based distribution approach as one of the high impact interventions. Now, we also had their capacity built in terms of making reports and reporting timely, especially on familiarization on the tools that they have been able to report accurately and on time. Then there's also a component of referral. They didn't have good skill in the referral, but as I talk, they're able to refer clients and are able to also follow up. Then as a geography, after the graduation, we have tried to strengthen this component since the fact that we have a meager budget. So we see services or the community-based component into other activities. To be more specific, we had a water and sanitation drive that was in July last year. We had one in Feb, we had July, that was a few months ago. So we try to integrate this activity with family planning so that as a member of the village health team visits a household, is talking about water, sanitation, malaria, he's able to pass a message about family planning and also distribute a commodity. As I talk right now, we are having an oral cholera vaccination campaign that is running on. It started on 6th, that was the other day, and it's ending on Friday. We have also been able to integrate the same service with the oral cholera vaccination campaign. So a message about family planning is being passed on. Now, during the quarterly review meetings, when we are discussing our reports, we are able to invite a representative of the VHTs to also discuss issues of family planning. They're able to identify gaps, good lessons, the achievements, the challenges, and are also discussed. And we also have an integration as regards to motivating our VHTs, most specifically as regards to logistical support. The district received 150 A12 Android Samsung phones, bicycles, bags, umbrellas, but our priority in the municipality were VHTs who were based in community-based distribution of family planning commodities. So this is going to help because we have oriented them on how to use the Android phones in ensuring that they report adequately and on time. Then on active family planning champions that support advocacy campaigns, you realize that when we had the support of the TCI, we were supported to come up with a structure. Those are the champions, and these are multi-sectoral in nature. That means that we have a member of the religious leader, we have the Catholic, we have the Muslim, we have satisfied users, because these are very key as they command a voice within the community. And then we also have the service providers. Now, we have set a system as a geography where we involve now the active family planning champions. And to be more specific, we have one of our leaders who is called Honorable Baraza, whom we have always moved with to our radio talk shows, because we have radio talk shows supported by our other implementing partners that talk about nutrition, malaria. So we are able to invite them and then they pass a message. They're able to also dispel myths and misconceptions about this. So that is as far as we have gone to ensuring that our champions are active and are helping us to pass out the message about family planning. Then on year-to-year increase, in allocation towards family planning service delivery in Busia municipality. As I had earlier said, of course, as I had earlier said, we did not have a budgetary allocation towards family planning services in the municipal, and of course, we did not take it as an issue. But as I mentioned earlier, you realize that in this financial year's allocation, we have a 2% allocation towards family planning services, and is expected to raise to 5%. That is by the year 2024, 2025. This is clearly indicated in our 5-year development plan. So you also realize that we have further ensured that we use the data that we have to inform us on the next decisions, and that is one of our key areas that we have strengthened in this area. But of course, due to COVID, we have had some challenges. We are also able to realize that we have a year-on-year increase in allocation towards this. You realize that we have a raise tool as a local government that informs us on a number of probably gaps, and where we are going, probably where we're having gaps, we are able to tap into the issues in our governance skills, in our budgetary allocation, in the data usage and the skilling. So it is able to identify for us the gaps and then informs us on the solutions in the years to come, such that we are able to sustain this. On finally, on number 5, that's adaptation of high impact interventions. We realized that after the graduation as a geography, our high impact interventions have been the community-based distribution component, that is use of VHTs in distributing and sensitizing communities on family planning. We had the outreaches, in-reaches, and whole site orientation. But we have we realized that we needed to really adapt and sustain these interventions. Now we have a structure which is the municipal health team that does the supervisory role on our facilities where these services are provided. So we are able to do this on a quarterly basis to really check and address a number of let's say gaps. We are able to reorient our service providers to ensure that these high impact interventions are sustained. Now, when you go to outreaches, as a geography, there are times where funds are not available on time. So we are able to integrate these outreaches into other outreaches. Now, last year when we were struck by COVID-19, we had to reactivate the dormant outreach posts for immunization. So we had to sit as a geography and we had to integrate this, the family planning component into the immunization, because there were restrictions in movements of the people. But since outreaches are within the communities, we realized that our clients were able to reach out to the posts. Now, on the community-based component as one of the high impact interventions that has worked well and perfectly in Busia. Of course, our volunteers are not entitled to any pay, but so what we do is to integrate the community-based component into other services, as I had earlier mentioned. Just like I talked about, they are motivated through the logistical support. At times when we receive these items, we have to support specifically the VHTs who who have done what, who have been involved in the family planning. Now, we were introduced into the TCI University, where we find a lot of information, which is our good Bible. And we have had a number of the providers and the leaders and other stakeholders enroll into the university. And this has been our Bible into seeking information about the high impact interventions. So that is how we have moved into the strengthening of the community-based component as a high impact intervention. Now, on the next slide, it is as Busia, it is showing us how we have performed on the permanent, the short-term methods, and the long-acting reversible contraceptives. Now, when you look at the permanent method, you realize that the curve is flat or constant. This is due to the fact that most of Busia has many youth, and most of our clients have been the young youth, and these people don't have families. So you realize that they're able to prefer the other methods as opposed to the permanent method. Now, on the short term, you realize that there has been an increase from 1819 to 2020, that is from 1608 to 3188. Now, one of our high impact interventions, which is the community-based distribution component, has really done us a favor. The VHTs who are on the ground are able to reach the clients in their homes and distribute this. And given the fact that most of our clients have been the younger people and don't have families, so they prefer the short term. Now, when you look at the lakhs, there has been a fall drastically from 1819 to 2021. This has been due to the fact that one of the reasons is the youth, of course, prefer the short term to this. And you also realize that in this period, after the TCI, we are transitioning and we are adapting. So that explains the fall in this in the long-acting reversible contraceptive methods. And I think I can end there for now. Thank you so much for listening to me.
Thank you so much, Dick, for sharing the experience from Busia municipality. Indeed, we've seen some great achievements that the municipality has been able to achieve around family planning, adolescent youth sexual reproductive health program intervention. We've seen how the geography has been able to institutionalize the high impact intervention into the county work plan. We've seen an increase in uptake and how you've been able to integrate the services into other services. We do acknowledge the challenges that the municipality has experienced, and more especially around during the COVID period. We've seen how the uptake of family planning has gone down, but we believe that with the institutionalization of these approaches into your work plan, we'll be able to start experiencing an increase in the client volume post-COVID period. So just as a reminder to our presenters, please, to our audience, please, in case you have any question, type in the chat box. We'll be able to go through them and they'll be answered at the end of the session. So at this juncture, I want to welcome the presenter from Tanzania. Welcome so much. Kindly give us the experience from Tanzania. Rehema.
Thank you, moderator. I'm here to present. Good evening, good afternoon, good morning, everybody. I'm Rehema Panga, District Reproductive Child Health Coordinator from Ubungo District. I'm here to share experience from Ubungo Municipal in Tanzania. And the Ubungo Municipal is among the 5 municipalities graduated in Tanzania. To start with, we had institutionalization. Ubungo Municipal has been able to adapt high impact interventions into our comprehensive council health plan. And those interventions include outreaches, adolescents and the youth dialogues, and the sensitization to ensure that we can get results. Previously, we used to do outreaches with no sensitization in the community without engaging the community leaders. But through TCI support and the TCIU, we have been able to improve on how we do better high impact interventions. And another area is advocacy with council and the community leaders. In area of advocacy, before TCI, our family planning budget was minimal. However, through engagement with facility in charges, councillors, members of parliaments, council management teams, council health management teams, we do advocacy meeting on our budget. And this result us to increase in municipal budget from 34 million on 2017-2018 budget, and increase yearly up to now in 2021-22 comprehensive council health plan. We put 195 million for implementing the high impact interventions and all family planning related supplies, commodities, and the equipments. On the area of strengthening healthcare providers, before TCI, we had few providers with skill on postpartum family planning, but through implementing the TCI activities and the TCI support, we have built a capacity to 34 healthcare providers on postpartum family planning. Also, we trained 5 providers on TOTs, trainers of trainees. These trainers of trainees assist us in mentorship, coaching, and doing training for other providers in our municipality. And this helped us to reduce the huge number of women of reproductive age to get these services. Another area is increase on MCPR. These high impact interventions increase our MCPR from 16.2 on 2018 up to 62.6 on 2020. And this is done on doing adolescents and the youth dialogue to secondary schools, universities, out of school youth, also at facility levels. All these have contributed to increase our municipal CPR and a reduction of teen pregnancy up to 17.3%. Next slide. As we see, this is a trend of volume of clients at Ubungo Municipal. As we started on 2018 up to the 2020. The brown one, the higher one is for LAC, long active reversible contraceptives. As you see, this graph is always going up. And the second line is for short-term family planning methods. We had improvement. And the last one is permanent methods. Thank you for listening.
Thank you so much, Rehema, for sharing the experience from Ubungo Municipality in Tanzania. And it's great seeing the type of achievements you've realized in Ubungo in terms of increase in MCPR Actually having a more than 46% increase is very, very encouraging. Then also having a reduction in teen pregnancy of more than 16% is great. So at this juncture, I'm going to invite our next presenter from Kenya to share the experience from Kericho and Uasin Gishu. Welcome, Madam Assumpta, to take us through the Kenya experience.
Thank you so much, Nancy, the moderator. Thank you, team, for this wonderful session from Uganda and Tanzania. Thank you so much. So I'm going to take you through the Kenya experience. For the Kenya experience, we have had two geographies, which are the counties that started earlier, and they were among the first ones to graduate, that is Kericho and Uasin Gishu. And we have seen quite a number of our colleagues in Tanzania and Uganda. And here we can see Emily Cheres, the reproductive health coordinator of Kericho, explaining how this is possible without direct funding from TCI. And we can see her quote here saying that we have been able to incorporate what we used to do with TCI in our annual work plans, including the in-reaches, outreaches, whole site orientation, and on-site mentorship, and applying some of these approaches in other health programs. This was actually made possible with the capacity building, and the team has appreciated the fact that the capacity was built on the ground, particularly the existence of the coaches who understand the approaches very well as codified in the TCI University. And of course, some of these approaches have had the cost parameters, which was prepared by TCI, and this has assisted the team on the ground to include them into the annual work plans. We have also seen progress in terms of increase in financial contribution, which has moved with the over 7% for the period of implementation. And as we speak now, we have continued to do the monitoring, and we have seen this budget has actually more than doubled from the time we have had the experience with them. So we can move. Next slide. Yes, in terms of measuring the sustained impact, Kericho County was able to use the RAISE tool, which was explained earlier. And from round one, when we began the assessment, this was a self-assessment, they scored 49% using the 4 program areas that were assessed. Then they moved to 71, which was a plus of 44.9%. And then they sustained that increase up to 74 in the third round and 76 in the fourth round. They have continued to do these rounds, and this has also helped them in terms of identifying the areas that require improvement. For example, improved quality and frequency of coaching, financial spending, and use of data for decision making. And we have seen Kericho County introducing a financial expenditure tool, which they are using also to look at other programs and generally to understand what they have been able to put into the budget and how it is expended. There has been a lot of intensified coaching, and also with clear roles and responsibilities shared among implementers at various levels. And we have seen Kericho County also identifying the leaders, even at sub-county and facility level. Then, of course, the issue of regular feedback on action items with top leadership and other sector players. And this has also been very critical, particularly with the PMA survey data, which has been able to guide decision-making. And then coaching and strengthening on financial management and expenditure tracking. In Uasin Gishu, we have also seen almost a similar improvement, and some of the achievements in Uasin Gishu particularly include transition to alternative funding for for implementation of adapted farming, other partners supporting, and then incorporation of this AYSRH within reproductive and maternal neonatal child health, adolescent health budget, which is commonly known as the RAMCA. And most of the time, the partners will budget as the RAMCA. And also the county has done an integrated kind of budget, but FP is a component of the RMNCH budget. We have seen financial tracking for family planning. This has been made possible by the DSW, that is one of the implementing partners, and this has continued to inform the decision makers at the county assembly level on the areas of improvement. And then the county has continued to collaborate with implementing partners to address the teen pregnancy challenges, and we have seen them establishing technical working group and also stakeholder meeting where TCI has also been able to participate. They have been able to domesticate the RAISE tool, which is the reflection and action to improvement of self-reliance and effectiveness, to other programs, and they have an M&E office that has facilitated this. The picture we are seeing is about the graduation, where the county executive member of health, that is a senior executive member from Uasin Gishu, who is seen there giving certificates to the best performing teams. And she said that we are happy to be on graduation. And she noted that this was an achievement. And she has continued to say that even though we have not improved well, we need to interrogate the data and ensure continuous improvement. And the county leadership is on top of things to provide that kind of support. Next. We can see here some of the sustained impact in terms of additional FP users from January 2019 to July 2021. This has so this has continued to be sustained, and we can see how the graph is showing this impact on additional users. This is generally in terms of all the methods accepted with the new users. Next slide. We have also seen the client volume, where we are seeing the short-term and the long-acting permanent method, long-acting and reversible method actually on the rise. TCI was not very particular in terms of permanent method because of what the cost that goes into provision of permanent method, but specifically on long-acting and reversible, that is where we have done the focus, and we have seen this actually being sustained. And this has been made possible by the existence of the strategic frameworks that highlight organizational priorities to reinforce the mission, and also the commitment from the top leadership, and of course the coaches on the ground. Yes, so some of the lessons that we have learned in terms of preparation for graduation is that early communication on the TCI graduation strategy with all the teams is very critical. There is need for engagement and communication with the key city leaders. This needs to begin early, and it's a process like we have been said. And so we begin with the end in mind. At the inception of the program, the communication about graduation needs to be put in place. And then of course, there has been institutionalization of the high impact interventions in tangible ways, for example, through the annual local government budgets, which has been highlighted earlier on. And investing during pre-graduation in building great partnership with other stakeholders and partners for continuity. For example, who is going to take over in the event that TCI is not there? Then developing graduation champions, and these are the people we rely on so much and we build the skills in terms of identifying and also using data for decision making. We have had champions who did very well being awarded and recognized for their input. And this is also very motivating for the champions to be on board. Some of the challenges that we experienced was packaging, communication, communicating the graduation agenda. Of course, it's not very easy, and some of the geographies felt like maybe they were graduated too early, prematurely, but we have assessed the systems, and that is where we realized that there is need to look at what are the parameters you are assessing. So the systems are actually very critical in terms of assessing the growth and development. Then aligning activities for a graduated geography, that is what is the minimum technical assistance that is required to ensure the gains are sustained. So definitely you need to be on the ground to do the monitoring, but again, we have been looking at how to come up with the minimum technical support without necessarily going back to supporting fully as the geography takes the lead. Next slide.
Thank you so much, Assumpta, and the other presenters for taking us through the East African graduation experience. Indeed, through your presentations, we've been able to see how cities across East Africa have been able to sustain some of the gains that have been made while working with TCI. So at this juncture, we are going to open up for Q&A session. And before we start the session, I'll try to read through the chats to see any question that has been raised that needs to be answered. So just to start us off, there is a comment from Jean. Jean is saying that it's more of a compliment, a very clear explanation of the TCI graduation process. So thank you, Jean, for the compliment. There is a question, and I believe this question goes to Uganda team, Dick. It's from Doki Simon. He says, a great presentation. However, one challenge that I encountered while working with the village health teams at a time in northern Uganda was high turnover rate. How have you been able to sustain this, considering the supplies given to the VHTs and the Android phones? So Dick, kindly take note of that. Then there is a question from Oying. It's more of an observation. It is in regards to the graph from Uganda. So he's asking, is this graph reflective of the impact of COVID on services and demand? Dick, also take note of this. There was a response from Nathan. So Nathan has just answered the question. He says, true, COVID has had a negative impact regarding FP uptake due to the movement restriction and the stigma or fear associated with the pandemic. So thank you for that response, but you can add more. There's still one more from Oying. I wonder, in the case of Uganda, how much of the decline in lakhs and increase in short-term method was affected by COVID? For instance, in India, we are seeing the same phenomenon of temporary decline in lakhs and an increase in the short methods that community health volunteers can distribute or dispense. So kindly, Dick and the team from Uganda, you can also note this particular question and try and address it. There is a comment from Mahin. Mahin says that glad to hear that TCI high impact interventions have been institutionalized. Thank you, Mahin, for the compliment. So at that juncture, I'll invite Dick to try and address some of those questions before we proceed. Welcome, Dick.
Thank you. for those questions and observations. One of the questions has been answered, but I needed to respond to one member observed that in northern Uganda, there are so many VHTs, and is wondering how we are able to support the many amidst the few Android phones we received. The TCI supported us in building capacity of 100 VHTs, but the most active ones are 60. And what we did, because we had the limited number of Android phones, we only considered the most fast active 20. But we hope that as logistics come, we shall be able to give to this specific number of 60 to actually motivate them. I want to appreciate the decline in lakhs. Of course, I had earlier explained this. When you look at the graph and the figures, I said due to the fact that our community-based distribution component is very strong, you realize that most of the short-term commodities are taken nearer to the clients in their homes and are able to reach them. Although we had a restriction in movement due to COVID, but we're able to realize it. And I also mentioned that most of our clients are younger people and do not have families. And the fact that most of our clients are the young people, so they prefer the short term to the long term, and that explains the decline in the consumption of the long term. Thank you.
Thank you so much, Dick, for attempting to answer the question. So we'll continue to peruse through the chat box.
Well, 1 minute, Nancy. It looks like Nathan might also have something that he'd like to support or follow up from what Dick said.
Okay, thanks, Lisa, for that. Nathan, kindly go ahead.
Thank you, Nancy. I would like to just add a little on what Dick has just shared regarding the graph that was shared, which shows we see there's a decline, continued decline in the lakhs. And then there was a question regarding COVID. What the trend that we observed is that it's true, COVID-19 has had a negative impact regarding FP uptake. We have seen an increase in teenage pregnancy, that's all over the country. We've seen again, there was a decrease in lakhs uptake, but this is, because we try to dive into the data and try to get meaning out of it. We observed that, which is true, when COVID came in, clients or potential clients, shunned facilities. Initially, there was a lot of stigma before people had, conceptualized how it is spread and then what it all entails. So people are not moving to facilities. Actually, this didn't only affect FP, it affected other services, healthcare services in general. Wards were literally empty, admissions were few, OPD clients were few. Now, this had a negative impact regards to FP uptake. So he brought out the component of the community health workers that really played out well and helped and to take services to the people. The VHTs were also used during the COVID interventions. So the very people, because one way they're motivated, let's say, take case in Busia, they have no remuneration, true, but programs that come up, these very VHTs are the ones that are used. And programs come with, the small stipends just to motivate them. Either it could come in terms of small, monies or just t-shirts, whatever the package brings to keep them active. So they were able to move to the respective, homes, to the villages, and they would come back and meet those that needed FP. The VHTs give out the short term strictly. They give out the Cyana Press, they give out the Depo-Provera and the condoms. Now that explains why even during COVID, we continue to see that the graph for short-term methods was sustained. It kept increasing. So COVID really did affect us. Thank you. I thought I should add that.
Thanks, Nathan, for sharing the reasons as to why there was a decline in the lakhs and an increase in the short-acting reversible contraceptive methods. Any other inputs from Uganda before we go through other questions? If there is none, there's another question from Oying for Tanzania. He wants to know, how was the decline in teenage pregnancy calculated, considering that Tanzania had almost 17% decline in teen pregnancy? We've seen Mahin has tried to answer Oying by stating that it's usually calculated from the antenatal care data. So Team Tanzania, you may need to elaborate more on this. There is a comment from Sarah. This is more of a compliment. Sarah says that it's very interesting to learn how helpful it is to create cost estimates in order to incorporate high impact interventions in government annual plans. It's impressive to hear of how work plans are incorporating high impact interventions in government annual workplaces. It's impressive to hear how work plans are have incorporated high impact interventions. Then she goes ahead and says that everything still boils down to the state peculiarities. For example, we've had states where the 72-hour makeover that have conducted 72-hour makeover. We've equally had states that have conducted enriches, whole site orientation among different intervention of services. But we've also gotten feedback where states are giving feedback that the 72-hour makeover was the best thing that ever happened to them and was very, very effective. There is a comment from Paul trying to address the decline in the numbers. Paul states that Busia is a border town and we've seen more impact related to COVID movement restrictions. Thank you, Paul, for the input. There is a comment from Mary. Mary is more of a compliment, great experience. Congratulations to all the presenters. Thank you, Mary, for the compliment. There is a question from Sarah. Sarah would like the panelists to talk about how easy or hard it is to have high impact interventions included into the annual work plans. And once something is in the work plans, does it tend to stay there year after year, or how does it happen? So Team Tanzania, Uganda, anyone can address the question of the high impact interventions included into the annual work plans? And probably further elaboration on how teenage pregnancy reduction was calculated in Tanzania. So panelists from Tanzania, Uganda.
Okay, hi Nancy, moderator, and hi everyone. This is Tumaini from Tanzania. Thank you for the good question, but I also thank Mahin. She has tried to answer from our end. So just to respond to it, this data is normally calculated from the DHIS system, the data that are coming from the government system. We have asked Charles to join. I hope he will be in a good position to describe it more. Thank you.
Thank you, Tumaini. Charles, would you like to elaborate further on how the teen pregnancy reduction rate was calculated?
I'm not sure whether he has joined already. This is Rose, but it's just the way Tumaini said, and also Mahin had responded. We have very high ANC booking. The percentage is really good, around 19 and something. So young mothers also attend ANC clinic. And we believe that most of the young mothers attended to the ANC clinic are registered in the ANC register books. And from the ANC register book is where the data now is extracted, and we get the accurate information from the HMYS information.
Thank you, Rose, for the elaboration. Could you please talk to how hard it is to have the high impact interventions included into the annual work plan? And once they have been included, how easy is it for counties or for cities or municipalities to have them stay into the annual, into the county plans?
Thank you, Nancy. Yeah, and thank you, Sarah, for asking that good question. We can say it's hard, but it's not hard, but with continuous advocacy to high-level decision makers and politicians, who are the ones who are really the ones who are deciding during the budgetary debate or discussion before the budget is taken to the parliament. So the budget starts right down from the council, and the council members are the ones who discuss that budget. And also the technical people are part of that council. So once we also go there and do the advocacy to high-level decision makers, the politicians, then also giving them results, as how Rehema showed the CPR increase. So it motivates them and see, oh, this is which is good. And also we show our contribution, the TCI fund, how it has helped to like ignite the local government to show the way on how to put money, put more money. Like if you see most of the local government, they started with very little budget. But as we are talking now, we are at 100 and something to some of the geographies. And this is through advocacy that we do on like biannually or on quarterly basis when we meet with these decision makers. Thank you.
Thank you, Rose, for sharing with us how the process of ensuring some of these high impact interventions are incorporated into the county plans. Yes, Nathan, do you have something to add, please? Go ahead.
Okay, just add a little on what Rose has shared. It's the same, this other side, but I just want to pick on a small addition. Remember, the funding of the question FP is picked from the local revenue. So the first point is that how much local revenue will be collected. If we've had catastrophes or challenges in collection of local revenue, it will have direct impact on how much will be allocated. But when it comes to sustaining the high impact interventions in the year in, year out, year in work plans, one other intervention that is done, we have the CSOs that each time there's, districts have their cost-state implementation plan. So they hold these districts accountable. We attend or sometimes facilitate these meetings, but the essence is to dialogue with the key stakeholders, and among those are the political leaders of a given location and the technical leaders. And we look at the budget. We hold them accountable. You committed this much to sexual reproductive health. How much are you releasing? How much have you spent? So it all comes back to advocacy. It comes back to holding them accountable, reminding them of the promise and commitment. That's how we've seen them, keep the commitment. Thank you.
Thank you, Nathan, for the addition. So I'll continue perusing through the charts. There is a comment from Jerry, and Jerry says that great webinar presentation. She's trying to elaborate that in East Africa, 20 cities have successfully graduated on their journey towards self-reliance, are leading their family planning and adolescent and youth sexual reproductive health programs without the TCI direct support. She says that this was achieved through institutionalization of the TCI high impact approaches into the graduating geographies work plan for the coming financial year for purposes of budgeting and continuity. Thank you for that clarification. I'm not seeing any more questions. Let me just.
Nancy, I noticed that there's 2 questions from Jen Snell specifically for the East Africa Hub team to reflect on in the Q&A. And she wanted to know, how does the East Africa Hub take into account support from other technical and financial partners operating in the cities? And then she also mentioned how turnover of trained staff is a huge problem in the FWA hub, and how do cities in East Africa mitigate this challenge post-graduation? I think those are the last questions that we have. So it'd be great to hear from the East Africa team about that, and then we'll get ready to wrap up.
Thank you, Lisa, for highlighting the 2 questions from Jean. Paul, would you like to take the first question? How does the East African Hub take into account support from other technical and financial partners operating in the cities? Either Paul or any of the country leads, Peter or Rose?
Thank you very much. I think I just want to sort of follow on that question and try and share what we have been doing in terms of liaising and partnering and collaborating with other partners on the ground. I just want to mention that the work planning process basically brings together not only TCI, but also other partners who are operating in that particular county. So what we do is do in a collaborative effort, the two, or rather the county sort of brings together TCI plus and includes also other partners working in that particular area. And in those work planning meetings, that is where we are able to share and discuss and see what activity are we able, is each partner able to support. So one partner may be able to support 1 or 2 outreaches, another one may support another advocacy. So basically, during this work planning meeting processes, that is where we are able to share and sort of come together as partners in that particular geography or that particular region. We are working together and we bring in, each partner brings in their expertise and includes also where possible resources. Thank you.
Thank you so much, Peter. Any more input from East African Hub, or now you work with other implementing partners at city level? There was the second question on the turnover of trained staff. On the turnover of trained staff, somebody is saying that it's a huge problem in their hub. So how does cities in East Africa mitigate the issues of staff turnover, especially post-graduation? Assumpta, would you like to address this, or any other hub staff?
Thank you so much, Nancy. In terms of staff turnover, most of the time you find the staff is being taken to another facility or sub-geography for those within. And for TCI, I think that is a plus because it is kind of the fusion to other sub-geographies or even facilities. So it's not all lost. However, TCI has made sure that there are coaches, which we refer to as Sisi kwa Sisi for Kenya, East Africa. And in the Sisi kwa Sisi is like south to south skill transfer, where these coaches are actually mentoring and coaching everyone within their localities at par, from facility to facility, from sub-county to sub-county. So this has been continuous, and kind of we used the existing structures to identify the coaches and to provide the technical support. So this has been continuous, and even as we graduate, we have maintained that kind of support, so that on demand, we will be able to provide ongoing coaching, either virtually or one-on-one. And sometimes we have also supported the other activities post-graduation in terms of monitoring. And once we have identified, we'll be able to link and see how to fill that gap. Thank you.
Thank you, Assumpta.
Maybe also to add, sorry, Nancy,
Yes,
just to add
go ahead.
To add on to what Assumpta has said, the coaching process is a continuous process, and it happens within the geography and within the counties and the geography you are working. And what happens is that the fact that the already trained coaches are also through the CC establishing and supporting and training other coaches within the geography. Even when one is transferred, we still have the resources within the same geography. And as she has correctly said, the ones transferred is an opportunity for us in the area or in the issue of diffusion and making sure that the TCI model is rolled over even into other geographies without our direct intervention. So thank you.
Thank you so much, Peter and Assumpta, for taking us through the process of addressing staff attrition. So if you don't have any more questions.
I guess, yes, I wanted to add on the.
Oh, go ahead, Rose, go ahead.
Yes, I wanted to add on high staff turnover. Still, we, together with the coaches that are on ground, we also have the TCIU, which the toolkits are self-explanatory, and for anybody who has who is going through TCIU kit, call it's FP or AY, it's very easy for them to understand the process and also get a little external support on the coaching so that she can also be expert in implementing most of the high impact interventions. Thank you.
Thank you, Rose. And I've seen Mary Joseph has also added to the debate. She's indicated that there's the step down coaching at facility level. So in each facility, that coaches that 2 to 3 coaches that have been developed. Hence, when one is transferred, the rest are able to continue with coaching. So if there is no any question, I like on behalf of the TCI East African Hub, I want to take this opportunity to thank each and every one of us for finding time to participate in this important webinar. I hope the time spent has been worthwhile and learnings and adaptations have taken place. We are available for any questions or clarifications. For more information on today's presentation, we shall be able to share the recordings with you, and they'll also be posted or they'll be available on TCI University. So till we meet again, it's bye for now. And thanks everyone for finding time to join this webinar. Bye everyone.
Bye, Nancy. Bye, everyone.
Bye, everyone.
Thank you. Bye-bye.
Bye.
Bye-bye, everybody.
Bye.
Thank you. Bye. Chat work. Bye, 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 bye.
Mambo. Niko poa, nimeisha. Yani, wengine nilikuwa sina mic. Kwa hiyo zingine nilikuwa natamani kuongea. Kama ile nani pale kwenye data za nani pale, ilikuwa ni issue ya kusema tu kwamba tunatumia ANC data. Kwa hiyo ni sema sasa nilikuwa siwezi kuongea. Lakini mama amesema vizuri. Mama ameelezea vizuri. So kile tumependa pale ni data za ANC zimekuwa connected kwenye dashboard, kwa hiyo ile pale watu wanaweza kuona kwamba zile team pregnancies zinapungua au zinaongezeka. Yes. Kwa yes,
Haya, asante Afrika sana. Kuja hapa haijakamilika hiyo. Haijakamilika. Haya, asante. Shalifu, nilivyo mara ngapi?